Kawasaki disease, also known as mucocutaneous lymph node syndrome, is an acute, self-limiting vasculitic syndrome that primarily affects children under 5. First described by Dr. Tomisaku Kawasaki in Japan in 1967, Kawasaki disease is the leading cause of acquired heart disease in children. One of the most concerning long-term risks of Kawasaki disease is the development of coronary artery abnormalities, such as aneurysms or ectasia, which can occur in up to 25% of untreated cases, potentially leading to sudden death or ischemic heart disease. The Centers for Disease Control and Prevention, CDC, defines classic or complete Kawasaki disease by a fever lasting 5 or more days, along with at least 4 of these 5 clinical criteria: rash, cervical lymphadenopathy of at least 1.5 centimeters, bilateral conjunctival injection, oral mucosal changes, and changes in the extremities. Incomplete or atypical Kawasaki disease is diagnosed when a child presents with prolonged fever but fewer than 4 principal symptoms and may include supportive lab or imaging findings. Epidemiology shows that Kawasaki disease affects around 25 per 100,000 children under 5 in the United States, with a higher incidence in Pacific Islanders and Japanese Americans, and a prominent seasonal trend in winter and early spring. Boys are more frequently affected than girls, and 90% of cases occur in children younger than 5. While the exact cause of Kawasaki disease remains unknown, research suggests possible infectious, genetic, or immune response origins, with studies ongoing to identify the source. Pathophysiology involves an acute, self-limiting inflammation across multiple systems. In Kawasaki disease, the innate immune system plays a critical role, with neutrophils acting on coronary artery walls and immune-regulated changes affecting gene expression during the disease's acute phase. Diagnostic inclusion criteria involve children under 18 with a prolonged fever of at least 5 days, along with at least 2 symptoms of Kawasaki disease, or specific clinical findings that align with KD. Children over 18 and patients with complicating conditions, including major chronic inflammatory diseases or Kawasaki disease shock syndrome, are excluded from typical KD treatment paths. In severe cases, KD shock syndrome can lead to potentially life-threatening complications marked by systolic hypotension, poor perfusion, and laboratory markers like higher inflammation, anemia, and low albumin levels, often needing treatment adjustments. Differential diagnosis includes ruling out other vasculitic conditions, as well as immune-related syndromes. Kawasaki disease requires early detection and management to avoid serious complications, with intravenous immunoglobulin (IVIG) therapy often effective in reducing symptoms and promoting recovery. In summary, Kawasaki disease remains a complex and critical condition in pediatric health, requiring continued research and awareness for effective prevention and treatment.